Hello, everybody. In this section, we will be covering trauma and stressor-related disorders. In this section, we'll be covering reactive attachment disorder, disinhibited social engagement disorder, post-traumatic stress disorder, otherwise known as PTSD, acute stress disorder, and adjustment disorders. Starting with the criteria for reactive attachment disorder, it consists of A, a consistent pattern of inhibited, emotionally withdrawn behavior toward adult caregivers manifested by both of the following. 1. The child rarely or minimally seeks comfort when distressed, and 2. The child rarely or minimally responds to comfort when distressed. So with this, you have a child who either, when they're having a difficult time or just regular situations where it's fairly normal for a child to seek out comfort and they don't, or if someone offers that comfort and that support to a child, they will have little to no response to that. So for example, if you see a child crying and you go to hug them or comfort them, they might stiffen up, they might pull away completely, that sort of thing. Or if they're in distress, they'll just kind of power through it on their own, and it won't even occur to them to seek comfort. And then next up is B, a persistent social and emotional disturbance characterized by at least two of the following. 1. Minimal social and emotional responsiveness to others. 2. Limited positive affect. And 3. Episodes of unexplained irritability, sadness, or fearfulness that are evident even during non-threatening interactions with adult caregivers. So just having sort of any abnormal reaction to others, especially adults. It happens obviously with other children as well, but you'll especially see this with adults because there isn't that instinct to trust adults. So anything that looks like being a position where an adult is involved or trying to give you comfort or something where that trust of an adult is required, you won't get it. And if that tries to happen, there's either a shutdown response or an overreaction to that, even when the situation doesn't pose any threat. Continuing with the criteria for reactive attachment disorder, we have C. The child has experienced a pattern of extremes of insufficient care as evidenced by at least one of the following. 1. Social neglect or deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caregiving adults. 2. Repeated changes of primary caregivers that limit opportunities to form stable attachments, such as frequent changes in foster care. And 3, rearing in unusual settings that severely limit opportunities to form stable attachments, such as institutions with high child to caregiver ratios. So if a child spent a significant amount of time in a child psych unit where like the attention is stretched pretty thin, and so it can come out of that. And then next we have D, neglectful care responsible for disturbed behavior. E, criteria not met for autism spectrum disorder. This is especially important because what this speaks to is within autism spectrum disorder, there are cognitive delays that attribute to the ability to form meaningful connections, especially with adults as a child, and that's because that ability isn't there due to the cognitive deficits that can be present in autism spectrum disorder. And so it's important to make sure that we are not attributing reactive attachment disorder where autism spectrum disorder, or really even though it's not listed, anything that could speak to the cognitive lack of ability to form meaningful emotional connections and to bond with caregivers. F, disturbance is evident before the age of 5. And G, the child has a developmental age of at least 9 months that's required for diagnosis. And so a child might not be physically 9 months old, but if they're developmentally 9 months old, then that criteria is met for the diagnosis of reactive attachment disorder. If, of course, all of the other qualifying criteria are met as well. Next up is disinhibited social engagement disorder, and that is defined as A, a pattern of behavior in which a child actively approaches and interacts with unfamiliar adults and exhibits at least two of the following. 1, reduced or absent reticence in approaching and interacting with unfamiliar adults. 2, overly familiar verbal or physical behavior that's not consistent with culturally sanctioned and with age appropriate social boundaries. So, for example, anything that goes beyond what's normal for how that child was acculturated and with boundaries that are within line of their age developmentally. So, for example, some children are brought up to be more extroverted and open and things like that. And so, if that's consistent with their culture, then that might be appropriate. But anything that goes beyond that is how we would meet this particular criteria. 3, diminished or absent checking back with adult caregiver after venturing away, even in unfamiliar settings. And 4, a willingness to go off with an unfamiliar adult with minimal or no hesitation. And then next is B. Any of the above is not limited to impulsivity. So, for example, ADHD can attribute to a lot of impulsive behavior, but it doesn't necessarily account for being disinhibited socially. So there is a component of impulsivity, and there has to be that inclusion of that socially disinhibited behavior. Continuing with disinhibited social engagement disorder, we have C. The child has exhibited a pattern of extremes of insufficient care as evidenced by at least one of the following. 1, social neglect or deprivation in the form of persistent lack of having basic emotional needs for comfort, stimulation, and affection met by caregiving adults. 2, repeated changes in primary caregivers that limit opportunities to form selective attachments, such as frequent changes in foster care. And 3, rearing in unusual settings that severely limit opportunities to form stable attachments, such as institutions with high child to caregiver ratios. Next is D, neglectful care responsible for disturbed behavior. And then finally E, developmental age of at least 9 months required for diagnosis. And again, with that one, to reemphasize, a child might not physically literally be 9 months of age, but if they are so developmentally, then they have the potential to meet the requirements of this diagnosis. And as you've probably noticed, there is a lot of overlap in the criteria for reactive attachment disorder as well as disinhibited social engagement disorder. And so something to keep in mind to kind of help differentiate the two is that the expression of reactive attachment disorder is very internal. It has a very internal manifestation. So the child becomes incredibly inappropriately withdrawn, whereas with disinhibited social engagement disorder, it's the opposite. It's very external. The child is inappropriately external, outgoing, and again, like it says in the name of the diagnosis, disinhibited. And also, with that in mind, some similarities apart from the criteria is that with the specifiers, so as far as specifying it, you can specify if it's persistent for both reactive attachment disorder as well as disinhibited social engagement disorder. They can be specified as persistent if the criteria are met for a period of 12 months or longer, and they can be also specified as severe if the child exhibits all the criteria, like they meet all the criteria for each one. And so those are the only specifiers for reactive attachment as well as disinhibited social engagement disorder. So again, for both of those, if it's considered persistent, if a child meets the criteria for a period of 12 months or longer, and it's considered severe if a child meets every single criteria for each disorder respectively. So they have the same specifiers in terms of persistence and severity. And as far as differences go, the prognosis are a little bit different in both. There's very little research about the prognosis and potential outcomes of reactive attachment disorder, whereas with disinhibited social engagement disorder, there is a little bit more known about the prognosis, and with consistent treatment and consistent positive positive reinforcement, positive social engagement, healthy social engagement, particularly with caregivers, there is a potential to have a healthier prognosis than there is for reactive attachment disorder. And it's not to say that there is no good prognosis for reactive attachment disorder. It's just there isn't a lot of research that supports what those outcomes look like for reactive attachment disorder as opposed to disinhibited social engagement disorder. And if I had to guess, and this is me speculating and rambling, so feel free to ignore me and fast forward, but my speculation is that the prognosis is probably a little bit better for disinhibited social engagement disorder is because that potential to form those attachments is already there. It just has such such an inappropriate expression, but the potential is there because they exhibit it, just not in a way that is healthy and beneficial for the child. Up next is post-traumatic stress disorder, which I will be referring to from here on out as PTSD because I'm not saying post-traumatic stress disorder a bunch of times. I don't even think I can. So starting with the criteria for that, we have A, exposure to actual or threatened death, serious injury, or sexual violence in at least one of the following ways. 1, directly experiencing the traumatic event. 2, witnessing in person the event as it occurred to others. 3, learning that the traumatic event occurred to a close family member or friend. In cases of actual or threatened death of a family member or friend, the event must have been violent or accidental. And we have 4, experiencing repeated or extreme exposure to aversive details of the traumatic event, such as first responders collecting human remains, police officers repeatedly exposed to details of child abuse. Those are a couple of examples. And it's important to note that this does not apply through media, TV, movies, or photos unless it's work related. So for example, if you had a job that required you to review photos of violent crime scenes or things like that, then there is a potential to develop PTSD from that. Continuing with the criteria for PTSD, we have B, the presence of at least one of the following intrusion symptoms associated with the traumatic event beginning after the traumatic event occurred. Number 1, recurrent, involuntary, and intrusive distressing memories of the traumatic event, which can be manifested as repetitive play in children, whether this happens in play therapy or if they're in their own personal playground or on the playground at school or playing alone at home or with friends and cousins, whoever at home. You might witness this that way in children. 2, it's recurrent distressing dreams in which the content and or affect of the dream are related to the traumatic event. 3, dissociative reactions such as flashbacks in which the individual feels or acts as if the traumatic event were recurring. Such reactions may occur on a continuum, with the most extreme expression being a complete loss of awareness of present surroundings. So you actively feel like you're not just remembering that event, or the person isn't just remembering that event, they're actually there. They're reliving that physically, mentally, emotionally for them. Number 4, intense or prolonged psychological distress at exposure to internal or external cues, which these are known as triggers, that symbolize or resemble an aspect of the traumatic event. So having a psychological reaction to anything that might remind them of the event. And number 5, a marked physiological reaction to internal or external cues that symbolize or resemble an aspect of the traumatic event. And a lot of people who have PTSD describe their body feeling the exact way. And some people, in some cases, might actually position their bodies in a similar way that it was when they experienced the event or witnessed the event. So just having those physiological reactions. And it can also not just be with positioning of body, but for example, elevated heart rate, rapid breathing, sweating, those kind of things. And they may or may not be the exact physical reactions they had when they were experiencing those events. Up next is C, Persistent avoidance of stimuli associated with the traumatic event beginning after the traumatic event occurred, as evidenced by one or both of the following. 1. Avoidance of or efforts to avoid distressing memories, thoughts, or feelings about or closely associated with the traumatic event. And 2. Avoidance of or efforts to avoid external reminders such as people, places, conversations, activities, objects, or situations that arouse distressing memories, thoughts, or feelings about or closely associated with the traumatic events. And this one is particularly interesting because a lot of people who might have previously been misdiagnosed or believed to have had um, a disorder that speaks to social avoidance, such as social avoidance disorder, or something like agoraphobia, where people are scared to leave home. It can actually be attributed to PTSD if they're avoiding certain situations that's attached to any reminder of an event that they experienced. So this is an important rule out diagnosis for anything like social avoidance disorder or agoraphobia. More criteria for PTSD, moving forward with D. Negative alterations in cognitions and mood associated with the traumatic event, beginning or worsening after the traumatic event occurred, as evidenced by at least two of the following. 1. An inability to remember an important aspect of the traumatic event, typically due to dissociative amnesia and not to other factors such as head injury or something like a traumatic brain injury or substance use. And so dissociative amnesia has sometimes been referred to as selective amnesia, not selective in the sense that you're opting to do that on your own, but sometimes your psyche as a protective factor kind of represses certain aspects of the trauma or pieces of it entirely. 2. Persistent and exaggerated negative beliefs or expectations about oneself, others, or the world, such as I am bad, no one can be trusted, the world is completely dangerous, my whole nervous system is permanently ruined. So just having a completely different and negative outlook on yourself in response to experiencing this in a way that is exaggerated, in a way that's inappropriate. And then next is 3, persistent distorted cognitions about the cause or consequences of the traumatic event that lead the individual to blame themselves or others. So maybe even a false sense of control. If I would have done this, or if you would have done that, then here's how the situation would have played out, when in reality that isn't known. No one could really know that. So having just a distorted belief cognitions about what even caused the trauma in the first place. Number 4, persistent negative emotional states such as fear, horror, anger, guilt, or shame. And this can be experienced in and out of the presence of a trigger for the event. Just having that state all the time, even when you're not necessarily reminded of or reliving the event. Number 5, markedly diminished interest or participation in significant activities. Number 6, feelings of detachment or estrangement from others. So maybe if you feel some shame about the event, that's attached to number 4, which is that persistent of negative emotional state, that could potentially lead you to detach and be estranged from others because of that. It's not the only thing that contributes to that, but it is a factor. And finally, number 7, persistent inability to experience positive emotions, such as an inability to experience happiness, satisfaction, or loving feelings. And with this one, it's important to note that you were once capable of those things. There isn't anything keeping you from feeling these things, such as any sort of cognitive deficit or anything like that, but you just cannot experience these positive emotions any longer. And wrapping up the criteria for PTSD, we have E, marked alterations in arousal and reactivity associated with the traumatic event, beginning or worsening after the traumatic event occurred, as evidenced by at least two of the following. 1, irritable behavior and angry outbursts with little or no provocation, so nothing that really evokes that response, but it happens anyway. Typically expressed as verbal or physical aggression toward people or objects. 2, reckless or self-destructive behavior. 3, hypervigilance, always looking over your shoulder, worrying about what's going on in a way that can be perceived as abnormal. Even when no threat is present, you still have that when it's not necessarily warranted. Number 4, an exaggerated startle response, so having an over-the-top fearful startled reaction to the smallest thing. So for example, a child who hears their dog barking and they have a fear response, they might jump, they might hide, whereas previously, before they experienced that trauma, that dog barking, even if they weren't expecting it, wouldn't have necessarily fazed them. Number 5, problems with concentration. And number 6, sleep disturbance, such as difficulty falling asleep, staying asleep, or having restless sleep. So even if you are able to sleep, it's not really a peaceful, restful sleep. And F, duration of the disturbance, basically criteria B, C, D, and E, is more than 1 month. G, significant distress, impairment, and functioning across dimensions. And H is not better explained by a medical condition or any medications or any other substances or another disorder. And now that we've covered the basis of PTSD, we're going to have a look at what that looks like for children 6 years old and under. So starting with A, in children 6 years and younger, exposure to actual or threatened death, serious injury, or sexual violence in at least one of the following ways. 1, directly experiencing the traumatic event. 2, witnessing in person the event as it occurred to others, especially primary caregivers. And again, it's important to note that this does not include events that are witnessed only in electronic media, television, movies, or pictures. And 3, learning that the traumatic event occurred to a parent or caregiving figure. And this one is especially key in children, because children tend to think of their parents as invincible, and so anything that shatters that perception of their parents could have pretty detrimental effects on how that child perceives the world themselves, in association with the trauma or witnessing their parent or caregiver go through trauma. And so that's why it's especially jarring for children, one of the reasons why. And then moving into B, presence of at least one of the following intrusion symptoms associated with the traumatic event beginning after the traumatic event occurred. So number 1, recurrent, involuntary, and intrusive distressing memories of the traumatic event. 2, recurrent distressing dreams in which the content and or affect of the dream are related to the traumatic event. 3, dissociative reactions such as flashbacks in which the child feels or acts as if the traumatic event were recurring. Such reactions may occur on a continuum, with the most extreme expression being a complete loss of awareness of present surroundings. And again, you will see this trauma-specific reenactment occurring in play. There's a potential for that. Again, whether that's in play therapy or in just their playtime in general. And number 4, intense or prolonged psychological distress at exposure to internal or external cues that symbolize or resemble an aspect of the traumatic event. And number 5, marked physiological reactions to reminders of the traumatic event. And more criteria for PTSD for children 6 years old and under, we have C, at least one of the following symptoms representing either persistent avoidance of stimuli associated with the traumatic event or negative alterations in cognitions and mood associated with the traumatic event, and it must be present beginning after the event, worsening after the event. So the first dimension we have is persistent avoidance of stimuli, which is characterized by number 1, avoidance of or efforts to avoid activities, places, or physical reminders that arouse recollections of the traumatic event. And number 2, avoidance of or efforts to avoid people, conversations, or interpersonal situations that arouse recollections of the traumatic event. And so there's a potential for this to manifest as if a child thinks they're going somewhere that might be a reminder of the traumatic event, or people want to try to talk to them about the traumatic event. They might act out, they might lash out, they might have tantrums, or they might completely shut down. But that can be, again, potentially how that looks like when a child is acting out this particular dimension. And then the next dimension is negative alterations in cognition. So number one, substantially increased frequency of negative emotional states such as fear, guilt, sadness, shame, or confusion. Number two, markedly diminished interest or participation in significant activities, including constriction of play. So a child might even become more restricted in the way that they play. And number three, socially withdrawn behavior. And number four, persistent reduction in expression of positive emotions. And wrapping up PTSD for children 6 years old and under, as far as the criteria goes, we have D, alterations in arousal and reactivity associated with the traumatic event, beginning or worsening after the traumatic event occurred, as evidenced by at least two of the following. One, irritable behavior and angry outbursts with little or no provocation, typically expressed as verbal or physical aggression toward people or objects, including extreme temper tantrums. Number two, hypervigilance. Number three, an exaggerated startle response. So again, with the example that I use of the barking dog when we were talking about PTSD in general, the same can apply with a child. And number four, problems with concentration. And number five, sleep disturbance such as difficulty falling or staying asleep or restless sleep. Sometimes even within the sleep disturbance, children who aren't co-sleepers might become co-sleepers with their parents, or might become attached to certain bedtime rituals that they weren't before. That's what that could potentially look like. And then we have E, the duration of the disturbance is more than 1 month. F, significant distress, impairment in functioning across dimensions. And G, not better explained by medications or medical condition, substance use, or another disorder. And there is a lot of overlap between PTSD in adults and people older than the age of 6 and children, people 6 years old and under. There's a lot of overlap. A lot of the symptomology, a lot of the criteria, is identical. But what's going to be different is the manifestation of that criteria, what that might look like. And the treatment looks a little bit different in terms of how you would, because with children under 6 years old or younger, it can be a little bit more difficult to talk through this with them and to treat it in that way. So just being, if you're doing play therapy, being very mindful in that and giving them opportunities to still express what they're experiencing, but understanding that they don't have the same language and tools that adults might use to cope with this. And so that's where it'll look a lot different in your approach to working with someone if they're a child that's 6 years old or younger with PTSD. Moving on, we have acute stress disorder. So the criteria for acute stress disorder consists of A, exposure to actual or threatened death, serious injury, or sexual violation in at least one of the following ways. 1, directly experiencing the traumatic events. 2, witnessing in person the event as it occurred to others. 3, learning that the event occurred to a close family member or close friend. And note, in cases of actual or threatened death of a family member or friend, the event must have been violent or accidental. And number 4, experiencing repeated or extreme exposure to aversive details of the traumatic event, such as first responders collecting human remains, police officers repeatedly exposed to details of child abuse. And again, it does not include events that are witnessed only in electronic media, television, movies, or pictures, unless occupational. Continue with the criteria for acute stress disorder. We have B, presence of at least 9 of the following symptoms from any of the 5 categories of intrusion, negative mood, dissociation, avoidance, and arousal beginning or worsening after the traumatic event occurred. So starting with intrusion symptoms, we have 1, recurrent, involuntary, and intrusive distressing memories of the traumatic event. And again, this might show up as repetitive play in children. Number 2, recurrent distressing dreams in which the content and or affect of the dream are related to the event, and it might be frightened dreams or nightmares for children. 3. Dissociative reactions such as flashbacks in which the individual feels or acts as if the traumatic event were recurring. Such reactions may occur on a continuum, with the most extreme expression being a complete loss of awareness of present surroundings. So again, within this one, feeling as if you are actively in that event, reliving that event. And number 4, intense or prolonged psychological distress are marked physiological reactions in response to internal or external cues that symbolize or resemble an aspect of the traumatic event. The next category is negative mood, and the one criteria for this is persistent inability to experience positive emotions, such as an inability to experience happiness, satisfaction, or loving feelings. And again, I want to emphasize that this does not speak to not being able to experience those positive emotions if it's better accounted for by another disorder or a cognitive deficit, goodness, for that one. And now we're going to wrap up the rest of the categories and criteria for acute stress disorder, moving into dissociative symptoms. So number 1, an altered sense of the reality of one's surroundings or oneself, such as seeing oneself from another's perspective, being in a daze, time slowing. A lot of people who experience this symptom in particular describe it as having an out-of-body experience while watching yourself do something or engage in something, but like experiencing it outside of the body, watching yourself kind of do it. That's one way it manifests that's been described. And number 2, an inability to remember an important aspect of the traumatic event, typically due to dissociative amnesia and not to other factors such as a head injury or again something like a traumatic brain injury or any kind of substance use. The next category is avoidance symptoms. Number 1, efforts to avoid distressing memories, thoughts or feelings about or closely associated with the traumatic event. And number 2, efforts to avoid external reminders such as people, places, conversations, activities, objects, and situations that arouse distressing memories, thoughts, or feelings about or closely associated with the traumatic event. And finally, the final category is arousal symptoms. Number 1, sleep disturbance such as difficulty falling or staying asleep or having a restless sleep. Number 2, irritable behavior and angry outbursts with little or no provocation, typically expressed as verbal or physical aggression toward people or objects. Number 3, hypervigilance. Number 4, problems with concentration. And number 5, exaggerated startle response. So as you can see, there is a lot of overlap with acute stress disorder as well as PTSD. And so the main thing that differentiates the two will be duration. So be sure to check and look into the duration criteria for having acute stress disorder versus what's required for PTSD, because that's going to be your qualifier for which is which. Because again, the symptoms are so closely related and some of them are identical and completely overlap. So we've reached the final grouping of disorders in this section, which is adjustment disorders, and those are categorized as A, the development of emotional or behavioral symptoms in response to an identifiable stressor occurring within 3 months of the onset of the stressor. B, these symptoms or behaviors are clinically significant as evidenced by one or both of the following. 1, marked distress that is out of proportion to the severity or intensity of the stressor, taking into account the external context and the cultural factors that might influence symptom severity and presentation. And that's important because we always want to make sure that we are contextualizing this within the context of that person's culture, which differs. So you would look at it with a different lens depending on who you're diagnosing. And number 2, the significant impairment in social, occupational, or other important areas of functioning. Next is C, is not better explained by substance use, medication, or medical condition, or any other disorder. D, the symptoms do not represent normal bereavement. So any sort of grief or anything of that nature that is outside of the norm, and again, we take into account that entire person's context for bereavement. And finally, we have E. Once the stressor or its consequences have terminated, the symptoms do not persist for more than an additional 6 months. And this is particularly important in adjustment disorders because adjustment disorders are not as persistent as other disorders, especially the more pervasive ones like personality disorders, for example. Adjustment disorders are relatively more temporary in nature, and so if it persists once the issue has been resolved or the consequences have gone away, if the symptoms persist for more than 6 months after that, then it's probably not an adjustment disorder. And an adjustment disorder can manifest in response to a lot of things like moving, for example, starting a new job, losing a new job, not a new job, but losing a job, whether you're fired from that job or you quit that job, the ending of a significant relationship. So adjustment disorders can come about when you're having a difficult time adjusting to a specific life event. It happens a lot with people who become it can happen a lot, sorry. It can happen a lot with people who become caretakers for their parents, or they become the ones who need caretaking themselves after not having to need that for most of their adult lives. Or it can happen with divorce, separation, having a child, adjusting to a new role. So adjustment disorders can manifest out of a lot of different types of stressors, but they're usually pretty significant life events. Now let's look at the specifiers for adjustment disorders. I will spare you me reading you all of these, but just pointing out, especially with anxiety and depressed moods, you just want to make sure that the anxiety and depression is happening in response to whatever event is the catalyst for the adjustment disorder and isn't already pre-existing. And again, if the anxiety or the depression persists for 6 months after the stressor has been resolved or the consequences are gone, then you might look at diagnosing someone with an anxiety or depression related disorder. And adjustment disorders with these specifiers can also be co-occurring with something like generalized anxiety disorder, for example, or major depressive disorder. So it can be both. It can be I'm having this reaction in response to this event, plus some of this is already pre-existing for me, or there's an establishment for this to exist. So they don't necessarily rule out, but they can. And it's considered acute if the disturbance lasts less than 6 months, and is considered persistent or chronic if the disturbance lasts for 6 months or longer. And again, we're looking at the disturbance in this case refers to the actual event itself, if that makes sense. And I'm happy to clarify that for you further if you need me to. But like, if the disturbance lasts for 6 months or longer and there is no adjustment within that. And that concludes the section on trauma and stressor related disorders. If you have any questions or concerns or any clarification on anything, feel free to reach out to Amanda or myself, or drop in on one of the optional Zoom drop-in sessions. Thank you so much.